palpation. She has pain.
Okay. All right, so before we get,
Is that you want it right
right now just on her, if I squat down, can you see me?
here?
Okay. So with a lot of people's shoulders, I'm just gonna briefly talk about some common asymmetry. Like this, just when I talk about this stuff, I want y'all to think like these are normal human asymmetries. Almost any normal person will present something like this. This is just to give y'all some kind of context as to why certain things could happen on certain sides. It's very common for people to have a right side bicep, like proximal bicep, click, pop, tension, problem, annoyance, pain, whatever. A lot of the reason for that is a lot of people's rib cage up on the right side is slightly depressed and slightly like rotated back. It's really like the upper part is kind of internally rotated down, and then we compensate to find neutral by slightly turning into that side. So basically, if you think about the rib cage as like, this is like a normal rib cage. If these ribs up here where the shoulder sits, if these things are dropped in, your shoulder doesn't have that support underneath it to hold it. So you kind of dump forward. And if that shoulder dumps forward, the stress is going to live through that tendon that doesn't have that little bubble up underneath it. So it's almost like you're no longer, it's kind of like you're surviving off the tendon as an anchor rather than there being something to hold you up underneath. Super common. You won't see it in a ton of people, but it is like if you start looking for it and you pay attention to who complains about what, you'll be like, that's another right bicep, that's another right bicep, that's another right bicep, or not right anterior shoulder. Like I see it a lot. A lot of people's left shoulders are more limited in external rotation. A lot of that is because we have bad expansion in the ribs on the back of the left side. So if we take both sides of the rib cage, just generally speaking here, a lot of people are kind of like this. It's like you're twisted back, compressed here, elevated here, and you just end up in this, some micro version of this. So most of us are better internal rotators on the right. We're better external rotators on the right, and we're better internal rotators on the left. It's because of what's underneath that creates that. So all that to say, if you're dealing with people with shoulder issues, think about what's underneath the shoulder. Where is their rib cage potentially sitting? Where is their collarbone potentially moving or not moving? Obviously think about injury history and stuff like that, but most people's shoulder issues are a rib cage problem much more than they are a shoulder problem. And that goes into neck stuff as well, but we're not going to talk about neck too much today. So, is yours more one side or the other for what you have?
Trying to think.
Or is it just kind of bilateral because of...
Typically bilateral. I had some shoulder, like something with my nerve, and it was going down into my bicep
Okay,
on my
I'm good.
left last weekend.
Okay.
But I think it's normally both.
Okay. So, for right now, because the camera's more on this shoulder, right, Scott?
Yes.
Okay, so I'm going to move around on that side real quick. TJ, I'll swap with you. You want to keep the box? Or you can just grab the stool if you want. So we're going to bring this up. So for right now, I just want to see, and if we'll just get as high as we can.
Okay, there you go.
And I'm just going to kneel for now. So just want to give you all some like easy palpation stuff to help identify like bicep tendon. So if we get on the front here, you should be able to strum back and forth and find the bicep tendon pretty easily. So if we find the head of the humerus right here, it's round, it feels like a ball, it's pretty easy to palpate and feel for. You always want to find bony stuff first. From here, let's see if we can like roll that up in there.
Can I just like hold it, or is it gonna mess?
It's probably good there.
There we go.
Yeah. So find something that feels like a ball and a bone. Usually if you push on it, it's got a little tenderness to it, but it shouldn't be anything crazy. From here, if you just drop straight forward off of that, cover the front of the shoulder with a couple fingers, and then move the arm, internal, external rotation. If you feel for the little ropey thing underneath your fingertips, you might be able to see it right there. So if y'all can see the little pop. First, you want to find something like that. And then if you push on that and someone's like, oh shit, that hurts, good indication that could probably be the bicep tendon issue. If you're unsure if it's the bicep tendon itself, if you externally rotate the arm and you come off of that tendon and they say it hurts more there, it's probably not the tendon. But if you internally rotate into the tendon and they're like, okay, that gets really tender and sharp or acute, that's going to help you identify what structure could more or less likely be the issue. So a lot of people will actually have like an anterior deltoid, like shoulder stress. It could be more of like a supraspinatus stress, or even just a capsule stress in general. So when they're really externally rotated, like that's where they're going to feel more distress. There's also, the pec attaches up in here too. Some people will just be tender in there for a number of different reasons. But the big thing here is that you can just palpate to find your tendon. Does it hurt at all?
It's not comfortable, but it's acute.
Okay. And I'm going to have y'all each practice this so you can just feel for what I'm talking about, just so you know what's what. And this is really just is that the short head of the bicep? The one that attaches to the humerus? I always get them backwards. Or is it the long head?
The short head's on
On the acromion?
what do you call it? What's this thing here?
The
Scapular.
acromion.
Yeah.
Yeah.
Oh,
So that's the acromion. That's where the other part of the bicep attaches. So just so y'all can see the difference between the spacing, that's one attachment up here, which I'll help y'all palpate in a second. The other one's out here. So they're farther apart sometimes than you'd think. So just so y'all can see the gap there. They're both biceps. They both do bicep-related things. The older you get, the more you really just need one or the other. But they do different things, and I want you to know where they both are. But for right now, we're just going to take turns palpating Kim's long head. Who wants to go first?
The most interesting man.
You feel it?
Does that feel the same as what he was doing? No?
it's really close, but his was popping a little bit more. He was like more, I think, right on top. There it goes. Yeah.
And then where's the other?
So the acromion,
Right here?
yeah, so if you come up, hang in there, Kim.
That one's tender.
It's up in there. I believe that's it right there.
Go for it.
So should you feel
this
it
side?
going back?
You're not gonna feel much acromion. Don't even worry about that right now.
Okay.
I just want you to feel for what's the big bicep tendon. Kim, y'all be nice to Kim.
It's fun. No, I mean, just, that one.
So whenever you're palpating, just a general rule of thumb, your touch should be firm and confident no matter what. Healthy tissue should be able to be pushed on and be okay. A little discomfort is one thing, but something that's inflamed, angry, injured is going to tell you it's inflamed, angry, or injured. So your touch is your first feedback of what could be a problem.
This one's more than this one, and it's like I feel like it would be harder to miss this one.
Is he on the tendon? Good.
Yeah.
So
This one's better. You're still on it. and
do you,
this one- this
can y'all feel how it flickers
Yeah.
underneath your finger as you go back and
this
forth?
one's more acute than this one pops big time.
Okay.
There we go. It's
Cool.
So the flicker, yeah. But then if I just like hold it down, right?
So that's if you're going to work on it. For
Yeah.
right now, we're just identifying the tendon.
Okay.
Because I think a lot of the times we just kind of start guessing in there. Just want you to know what's what. And always like the structure of the tendon, you can strum that and follow it all the way up to where it starts to blend into the capsule. So you can kind of identify where it goes, and kind of you can almost start to evaluate acuteness of where the actual problem might be. For some people, it's like right at the musculotendinal junction, like musculotendon junction, where like the belly blends into tendon, where that'll be really tender. For some people, it's true tendon, and the higher up you go, it's like they're like, that's tender, oh shit, and they're like, that's a knife, like that's it. So it'll just help you figure out like, is this a muscle problem or is this a tendon problem? And they treat a little bit differently depending on what's going on.
The acromion, that was more, it almost felt like,
Perpendicular.
yeah, to me, maybe not, but yeah, okay.
Yeah. So the acromion is underneath that collarbone on that more lateral side. So you would technically get way up in that pocket, you go underneath the collarbone, and then there's a little bony knob up there, which I'm about to show y'all so you can really feel for that. So you guys, y'all good with the bicep tendon? Yeah.
Oh.
So,
I feel like it's right there.
so here, if you're ever just to locate the acromion. Here, relax. Don't worry about moving.
Okay, sorry.
So we get up in here. Come over. So again, we're gonna find bony landmarks first. So collarbone,
Yeah.
lateral to the AC joint, humeral head, and then if we just kind of come down off collarbone, we should be close, or we can come kind of lateral off the anterior surface of the humerus, and it should feel like there's a little. I think of it as like a fat head of a bolt or like a nail head that's right there.
Is that okay?
Now hold on, before you start going, if you're not sure, so this comes off your scapula. This is part of your scapula. So if you're not sure, Kim, try to move your shoulder blade around. So as she moves around, do you know how to really tuck the scapula back? Yeah? So if she really tucks it back, that should feel like it goes back. And if she really tries to flip it forward, it should feel like it points down. That's how you can help identify if that's it or if you're just poking on something else random. That bone is not going to move with the arm motion. It should be pretty still. You may feel soft tissue around it move, but that bone will stay stable. Well, we'll go one at a time on this so that way Kim's not trying to like dance on the table.
Oh, right. Move it. I'm not trying to move it.
So right now I just want you to see if you can find it. Like, you need to find it, you know where it is? The acromion. But really just find that bony knob. Feel like he's on it? Yeah? Now, TJ, your hands are probably big enough that you could actually potentially move her whole shoulder and feel how that, if that was part of the scapula, if the scapula tilted anteriorly, that acromion should point down with it. And if it tilts posteriorly, that acromion should point up with it to some degree. At least you can help identify it.
Ooh, you that one, got it. Okay.
Okay?
Yeah.
Cool?
Uh-huh.
All right, go for it.
I think I had
Play
cracked
with this one. Huh? Yeah, you got. I think you got mine too.
Yeah. So it's. I think she's said both times that her right bicep has been more tender.
Do it on mine.
Yeah.
So I can.
So we come in here. So that's it right there. And I wanted you. I was a little angry there. So some people, depending on where their shoulder posture naturally is, like some people that acromion is like right there in your face and super easy to find. Some people have like really weirdly shaped, like some orthopedics describe it as like, I think they say like just the hooks. I don't know if you've ever heard this before, Scott, but they say like some people's acromion, I think it's the acromion itself is either really hooked or really flat. And depending on the size of that, like those people shouldn't do overhead motion or vice versa. I don't know if you've ever heard that before.
Yeah.
I think it's kind of BS. I think healthy shoulders do healthy things, period. But just if you're ever like messing, as you palpate more shoulders and take mental notes, you might notice like some people's bony presence is like really big or really narrow and pinpointed. Or like the collarbone is like really low to the acromion. Like just take mental notes on what you're feeling as far as where the bones are. Like every time you palpate, just think of it as like finding a road map and tracing your roads. Because that's what helps you identify everything else.
Yeah, I think so.
Okay, y'all good on those? Okay. So if we're, let's see, how are we doing on time? Okay, we're doing good. So from here, the anterior or the lateral delt, we're just going to talk about delt in general for a second. I'm going to come on this side so the camera can see it. Do y'all know where the deltoid tuberosity is?
Like in between.
Look at those arms.
That little nook there.
Yeah. So I want to use you for Bryson. I want to use you for this one so we can see the a little bit better. No, I'm okay.
Go ahead.
Give your body a break from all the touching.
Holy crap. Yeah, I feel like something's shocked.
All right, you can keep your pants on though. Okay, so can you see like the shadow of his arm here? by chance, Scott?
Yes.
Okay, so for lean people, this is kind of fun sometimes. So if you just keep your arm here, if you just open your arm against me, you can just watch how it flexes. Like so you're looking for the pinpointed diamond,
Okay.
how it tapers, the triangle.
Right there.
So his deltoid tuberosity is going to be right in there.
That's where like I can't forget, like, isn't there an artery or nerve that runs, the radial nerve that runs?
Yeah, radial nerve, yeah. That sounds right, Scott, right? Radial nerve around the backside, more lateral on the arm.
That's what I think. That's what was missing.
Okay.
The other day
So relax.
where I looked it up.
So a lot of people who describe bicep pain sometimes will actually have this like kind of tendinitis-y problem at the deltoid tuberosity. That's because that's where that deltoid is really anchored. That's its own little tendon right there. We don't really think of that as a tendon, but for a lot of us, or for a lot of people, that can be a problem. Usually that's very much like a muscle weakness thing. Most people who will have that, it's like they just either train the absolute shit out of everything else and they suck at engaging their shoulders, or they're very deconditioned and they just don't have healthy shoulders.
I saw that a lot, like post-op with like slap tears. Like
Mhm.
after a couple weeks, people would be like, "Oh, it just like hurts right here."
Yeah.
Yeah.
And capsule referral pain too can just web and all over the place. But a lot of the times, like that deltoid, it comes up across the top and it kind of attaches across like the whole ridge here. So you've got a lot of connective stuff up here. If y'all have ever seen like really, really defined shoulders, or if you've ever been lean and had a really big pump, you kind of see like the little striated like attachment way up here. That deltoid is literally wrapped up around the top of that shoulder. So whenever you've got slap tear people or people who've got a capsular damage, that refers through the whole thing, and that the direction of that tissue is down this way. So this really
The radial median ulnar nerve go through the neurovascular sleeve that goes down to the tricep, the
axillary nerve. Okay. Good job, Scott. Thanks, because I totally forgot about that. Okay, so even if someone's not lean, you can still kind of locate this based off a lateral raise type motion. Everybody's kind of different. So like Bryson, if you push at me again, and if we get your arm a little up, so if he keeps pressure against me and he just follows me, you can kind of see how like the activation changes a little bit. I don't know if y'all can see that. It's very subtle. It's like the shadow changes really. So all that to say, like if you're struggling to figure out, go ahead and push against me. If you're struggling to feel what could be like the deltoid attachment, is what we're just going to call it from here, you can move the arm up a little bit, have them push, feel for how it changes. You can externally rotate, resist, see if it changes, bring it closer to the body, push against me, see if it changes, come a little up this way, resist, see if it changes. I personally usually find it like right about here. Go ahead and push against me. And I'll like grab like this and just follow the point. And once I get into here and just kind of a hard pressure to feel. It's usually tender on people if you just push on it. But I just want y'all to locate the anatomy and know where it is. So anybody want to try it? You want to try it? You can do it either side if you want to. And I show you the whole deltoid and where the big attachment is because this is just the deltoid. We talk about the deltoid as if it's 3 muscles that are separated, but it's one chunk of muscle that has 3 bigger like epimysial fascial encasings that I feel like we've kind of man-made. And within each of those 3 compartments, there's like dozens of little bundles within it. So this is all just a big pocket of stuff. Do you want to feel for it with the fascial stuff? Here.
No. I've been working instead of working out. That's why my arms are so small.
That's all right. You're lean naturally, so it works out.
It shouldn't pop like this part does, right?
No. Now everybody's anatomy is different. some people, I have met some people who just have like, their muscle structure is just different, so it almost feels like you could strum it. Yeah, love the love tap. If you're gonna test it, I like to hold right here so you can get good leverage, and then make him fight you for a second, so that way you can really feel just that engagement down to that focal point. Easy enough. That one's usually pretty easy to find. So just the thing, I think I kind of started saying it, but didn't really finish saying it. A lot of people will complain about a bicep problem, but it's really a deltoid stress problem. It can be. So when you're trying to identify it, if you know how to locate where the deltoid goes and you can trace the line of it with your fingers through palpation, you can follow it and better identify, is it an anterior shoulder problem or is it a bicep problem? And you can play with it that way. Lateral deltoids don't seem to get stressed a ton. Usually if someone's complaining of a lateral deltoid issue, they probably have more of like a infraspinatus, supraspinatus type of problem, or they probably have a neck thing going on, or their whole shoulders just shot to shit and they just need to work on the whole thing. Is that thunder?
That's thunder outside.
That's cool.
Storming hard.
Was it?
Where I left McKinney.
That's
Yeah.
cool. Okay, so for now, do y'all know how to locate? Should we do the chest, the pec attachment, just so y'all can delineate that real quick? Know the difference? Pec attachment.
I was thinking the acromion.
Okay, so pec. We come out here. You gotta be real strong for me on this one, okay? So it's usually pretty easy to see. Like Bryson's kind of lean, so you can usually just look at it and you can just see that coming down here. So if you go to close your arm in, you see that right there? Okay, relax. Push again. So a lot of the times we think of the pec as a pushing muscle. Fiber direction considered, it's an adduction tissue. It pulls things to center. So if you want to figure out where it is, have the client do something adduction-ish. So you can go this way, you can come up here, go again, and that makes it tight. And then as they're pushing, you can strum it and you can trace it all the way to the bone, all the way down into here. It gets a little tender there, probably. Relax. And you can just figure out where it attaches to the bone. So I find a lot of people, again, who have bicep issues will have, and especially like beefy guys who train a lot, or I think maybe they don't train very well, but they train a lot, they'll just have a pec tendon that's worn the hell out because they're not getting good range of motion, they're stuck short. It's like this intersection of nonsense up here where everything's kind of fighting together to do one job. But being able to really palpate tendon of the pec versus bicep a little higher versus anterior delt is really going to help you figure out where your problem is.
Feel my pec tendon. Is it tight and worn out? I think it is.
I got a massive one.
Yeah, I'm sure yours is like probably a strip of jerky just laying in there.
Mine's tender.
Yeah. Here's the thing, I mean, it's kind of hard to tell standing.
Like, is it more?
Y'all can probably feel this one on yourself pretty easy. So, if I sit, everyone's looking at. So I'll sit here. Can the video still see from here?
Yeah.
So, if you think about like the meaty muscle stuff here, chest, if you follow that little curve as it tapers, if I hold, pull across, there you go. And you just get in there. It should feel very dense, very hard. And it's a very strong piece of tissue. But you just want to figure out where it is. If we go behind that, you're getting into the coracobrachialis, which we're not going to talk about too much. That's if we get into like deep shoulder tendinopathy stuff, we'll get more into that. We won't worry about palpating for I just went brain dead. Subscapularis tendon right now, because that's going to take more time to find. You want to feel for it? Want to try it? You think you got it?
I think, but it's more on the arm than I thought it was.
It's more on the arm than you would think, yes. I think it's like the upper third of the humerus. So here, something I want y'all to see here.
The twisting.
The twisting. I'm going to set this on Bryson.
Oh, nice.
The rotation of the attachment. So the chest is rotational. The chest has a rotational direction. This is one of the things that separates between clavicular, sternal, and costal attachments. So costal rib attachment is higher, and then costal is lower, and clavicular is lower. I'm sorry, and then sternal is the big fat one we all think about that's right in the middle. So I just want y'all to see. And the big thing here is like, when I was learning this myself, I really found a deep appreciation for the taper of the tendon. Because it's interesting to me, like as the more I've worked on people and really paid attention to how I'm feeling, like how acute to the point some people are. So the better you can potentially get it feeling where that really blends all the way into the bone and following it all the way in. Some people respond so well to just a little push. Directional shove of that tendon or that attachment where it needs to go.
This way?
So it depends on which one you're on. So like if someone's complaining of issues up here, tightness up here, and you palpate, you find the attachment, and we're down on the lower, so if you want to do this on him as we talk about it. So if you were on the bottom portion of what feels like the pec attachment and you were to push directly like kind of up into it, you're pushing that tissue up. Your mindset and what you should believe and what you should think as you do this is my belief system, is we're pushing the tissue up towards the collarbone.
Into a slacked position?
Slack position or just telling it where to go.
Okay.
I think of it as just telling it where to go. We can apply like manual isometric forces and stuff like that as if we want to, but just I think of like whatever my hands are doing, I want the muscle to go where it's supposed to go. And we'll just leave it at that. Y'all have questions on that? Y'all have seen the spiral before of the attachment? Did you know it had that nice rotation flicker to it?
I mean, I've seen it now that I look at it, but I had forgotten.
Yeah. It's real. I mean, I forget how spiraled it is until I go back and look at this. And I always have this app up.
Is this the complete anatomy?
This is Atlas, Anatomy Atlas. I think Complete Anatomy is a little better. I think that's the one you have. Yeah.
I don't know. I typically look at everything separate. I need to layer multiple things together because this is a really good. I like that you can see all the
And then just going back over here,
nerves and everything behind it.
just let's get rid of this. So again, this is your pack attachment right on top. So if you're thinking about layering stuff, if you're finding the bicep tendon up underneath here, let's see if we get rid of this. Let's fade it so you can see better. So you see the little white section right there? Can y'all see that on there? So I just want you to just see where that tendon is underneath that whole anterior deltoid. Because you got a lot of deltoid that covers that bicep tendon. That's one of the reasons I want y'all to know how to palpate the bicep tendon directly. Because a lot of people just get anterior generalized shoulder discomfort, and if you just got to figure out where you're at. That being said too, you know, the deltoid comes over here and it lays on top of the chest. So a lot of people who, like I've had a lot of people I've worked with who complain about they just don't feel their chest. It's always arms and shoulders. If you think about where these things lay on each other and how they attach right here, some people can literally use their delts to do the job of the chest. Instead of it pulling this way, it's going to be more of like the arm gets pulled more up into like a flexion based push rather than like an adduction and internally rotated type of push.
Yeah, I used to have huge anterior deltoids and a small chest.
And that's super common, like super common. I have an inverted sternum, so mine like caves in really hard, so it's very, very difficult for me to get good expansion, and my everything wants to just drop in, because literally like that's just where it goes.
Andre doesn't have that.
Andre does not have that. Andre's pectacular.
Pectacular. You are pectacular, sir.
Any questions on that? Y'all good with that? Okay, so from here, if we're thinking, now I just want y'all to look at this just one more time, and then we're gonna go into some like manual directional stuff. So look at the striation of the tissue. Can you see this on the camera?
Yeah.
Yeah? Okay. So if we unfade that, just take mental notes right now of where the fibers look like they're going. The anterior deltoid is a little bit oblique, going lateral to proximal. Pretty vertical, but a little oblique. So if you really wanted to do the best work possible on something like that, you would want to push that tissue in an oblique manner if it was resting like this. So if he's here, you're going to push more kind of like up and in this way. But if he was more out to the side, that might be more of just a pure lateral to medial push. And this doesn't need to be perfect, but you just need to consider where the tissues actually are. Your lateral deltoid stuff is almost always going to be just straight up. Just from the outside going to the top, just pushing up towards it. The more, if you look at the whole lateral delt, the lower you get, you can kind of sort of argue like a little bit of, do I want to push more left or more right or more posterior, more anterior? I usually just, if I'm starting down at this attachment down low, I'm just pushing up from that spot. It does kind of like fan out and then come back, but you're not going to do that very often if you do. We won't worry about posterior delt. That one's got kind of a funny shape as it comes around. That's good to, if you guys ever struggle with training posterior delts, think about tissue flow, where it actually goes. Figuring out the path of that tissue makes a big difference when you're trying to train it.
I need that.
Okay. Y'all good on this? Got mental notes? Okay, so we're going to practice directional input into tissue. Okay? I'm going to get rid of that. All right, so TJ, I want you to find his bicep tendon.
Yep.
Go down the bicep tendon so you get more into the muscle belly of the bicep. And I want you to feel for where the tendon becomes less ropey and becomes more broad. And to feel the transition of tendon to junction to muscle belly.
Got it.
And I want you to make sure you've gotten into good muscle belly.
Okay.
Okay? So from here, we're gonna go through this pretty quick, but if you just pick a spot here, if you just lightly pull his arm down like you're lengthening the bicep, I want you to feel for where does it feel like it starts to get tightest the quickest. It should be like a gentle curve of tension. So as you get longer and longer, it should elongate like with you very consistently. What you're feeling for in terms of where you may need to treat is when it's like a soft pull and all of a sudden it ramps up and you feel like it gets denser underneath your arm or underneath your thumb.
Right in there.
Okay? So find your best spot, wherever you think that is. That's where you're gonna reapply or apply your pressure. You engage, and I would hold still once you find that tension point. Because at this point, you're now getting tension, because the body is sensing tension now. And now you're gonna give a manual directional input on where it would be contracting to. So if this holds still, and you push in and up, you're gonna you need to feel the directional push, like you're actually pushing the muscle. You may need to go a little lower. So you need to feel like you are actually pushing the tissue up towards the tendon, like where it goes, where it flows. Bryson, as the client, should be able to tell you, like I always ask, like, can you feel that I'm pushing the muscle up? Like, can you feel that he's pushing up towards your shoulder? Like, can you feel the direction of the push? That's like the magic right there when you're treating this stuff. Just a dumb dead pressure is good for analgesic effect and getting dumb dead pressure is good for analgesic and getting shit to chill out. But if you're trying to restore anything from a function standpoint, direction needs to be sensed on both ends or felt on both ends.
Bryson's more relaxed than he's been in years.
Have to go to sleep.
You trying to get more on the bicep?
You can. No, just feel around. So like
So
you can come down like way into here if you want to, because it might be easier to feel from down here. You may feel the split in the bicep. So I bet for Bryson, if you were to get more,
More in here.
so like that's the epimesial groove, that's the split. So one head is over here, one head is over here. So like there's like a crater there. You can feel that? So go ahead and feel that, just in case you haven't felt that before. So one side, the inside is what attaches up to the chromium. The outside is what attaches up to here. That's just good to know for general stuff. But I find a lot of the medial portion is what is tighter. So that's where you would probably double check the arm pull, feel the tension, how it gets tight. And this is an art form to master. Like, I don't expect you to just figure this out right off the bat. And what you're feeling for is the very subtle feedback underneath your hand of when does that thing get denser quickest? When does it feel like it doesn't want to stretch as much, or like it gets firmer underneath your hand? Any of those things?
I don't feel. I know what you're trying to refer to.
Yeah.
But I don't feel when it gets.
It's gonna take, it
dense.
takes some
Use the
practice.
force.
Use the force. I'm sure if y'all have ever looked
Fingers
over,
or your eyes.
literally, I'm sure y'all probably, you have to. I'm sure y'all have looked over and probably seen me, like I know me and Scott both do it, we just zone out hardcore.
I feel it get dense.
Like,
Oh,
Because your
like
eyes
there,
go into
but-
your fingers.
that's right, that's right. Put your eyes in your fingers, TJ.
Are your fingers hurting?
No,
So-
it's just like I feel like
Here.
I'm so like dumb heavy that I can't.
Let me
go
find a
this
sweet
circuit.
spot.
Your thumb's also bigger, too, but not me.
Been pumping these. Tell that.
It's like 2 sets per week only.
It's working.
So this is where what you may need, because you are only using one thumb, this is where multiple contact points help. So drop a couple fingers, even pressure to the best you can feel, move slowly. Which finger gets more pressure underneath it the fastest?
Your index.
The index. You can almost see it. Then you can go on there, test again, feel for where, right there. Because now I feel a tiny little wiggle, but I feel more movement underneath my finger than I probably should for such a small motion. And that's where I just hold, push it up, and I just live here.
And why are you doing this?
So just think of it like directional release for like a stuck fascial pocket. So when we do this, we're not thinking of moving the muscle. I want y'all to think of sliding the fascia within the tissue.
Just slide your fingers.
Because muscle's dumb and stupid. It just goes where it's told. The fascia is what communicates to everything in your system. So if you think about the fascia as what you're moving, gliding, sliding, when it releases, you will actually feel, you and your client will both feel like something underneath or internally just went and let's go.
You let it go.
Do you want to keep saying it? Okay, try it again with multiple fingers.
Well, you just released it.
No, I didn't.
I don't be able to feel anything.
And think about how each finger has pressure on it from the start, TJ. Everybody's middle finger is probably going to get heavier first. Middle or index finger probably gets heavier first.
Look, your,
Yeah, because my
your
fingers
pointer,
are not lined
his
up the same.
pointer
I
finger
can't.
pointing
So
to
feel like
you got to
see, you guys have more even.
change it. Look, you have to
use
change it.
different fingers.
They all three. You can admit. You
Okay,
have
but
to.
if I claw,
Don't claw.
I have to have even length.
So, just practice.
Okay.
Just
I'm
practice.
trying,
Just
I'm
practice.
trying. This was also a basketball issue because you're supposed to shoot with these two fingers.
Cool.
And I can't. I have to shoot
You're
with
a
my middle finger.
you're a therapist now.
It's the same problem though. You're supposed to be an index finger shooter, but
Bryson, just relaxing my hands.
So, and I mean, your finger pads have big surface area compared to the rest of us. Just because of that, like you have to probably have either a lighter touch or a firmer touch. Potentially, you're gonna have to play with this and figure it out. I would assume firmer, most likely. But you're gonna have to, yeah, it might be better for you to use two fingers and give yourself just two things to feel for. And just see which one feels a little tighter first. You feel what I'm talking about?
Yeah.
Yeah? Are you just saying that? Or do you feel it?
Yeah, I do stuff like
Okay.
this.
Okay. ART teaches something like this, right?
Pressure and tension, that's
Yeah.
all it is.
Yeah.
Yes. And when you get really good at it, you can feel layers.
It's yeah.
Layers of tension.
Yeah.
So you can go like really light and get one layer, or deeper and get a different layer.
Yeah.
You feel muscles that move over each other.
That's where it gets super fun.
I don't know if I've ever gotten that good.
Calf's a fun one to feel that. You can feel that with deeper bellies of the calf a little bit more. So we're focusing on the bicep because I just feel like it's the easiest one to practice this on. TJ, if you want, like at this point, you can move up here like through his shirt, and you can try to just feel for like the whole pec, and you can move his arm,
Are you flexing?
and just that's probably going to be easier to feel the difference between finger 1, 2, 3, as far as like how the tension goes. So you can kind of get a bigger, broader
Right in.
feel for it.
You're not doing anything? Maybe it's easy on this arm. Like, I think you're doing it pretty easy.
So play with going from there to the inside of the bicep. And like just play with covering fingers in different ways, different touches. A little easier to feel the differences there.
Okay, once I find the tension point, then what am I doing?
So this is where you would find your tension, maybe pull the arm back a little extra to maybe get like the sense of a tiny, tiny bit more tension. And then you just, that's where you would switch to thumb, index finger, whatever you want to engage with. And that's where you engage into it first and then push it up just enough to feel like you are actually sliding it. Are you still with us?
Yeah. Like feel like you're pushing up that way. A little bit. I mean, his felt more.
And it does help to get, like, I like a thumb, and really wrap your whole hand around the arm when you think you got the spot. Get a good grip, move everything.
And he was probably pushing a lot more.
I think so too, yeah.
When in doubt, engage it more.
His hand was sideways.
Huh?
Like whenever I looked at Scott's hand, it was like this versus this.
Yeah. I mean, once you've done it enough and you know what you're feeling for, you just,
You can find it with
yeah, it's pretty, it becomes autopilot. You figuring it out?
Yeah, so that's his groove.
Yep.
Right? And then kind of split. See, I feel like my arm just gets in the way of his, but
So that's, no, you were right the first way. I would go with that one, and then you adjust your body.
I just feel like I can't line these up right.
So you're gonna get as good as you can. It's never gonna be perfect. So this,
Like I'm stabbing him with my middle finger, you know?
so one of the
So weird.
one of the reasons I keep my table low a lot, so I can get more on top and into things easier.
Yeah.
One thing that I think you need to practice on is slowing down, because you jump around a lot and you move his other arm too fast. And right now his arm is already long, so whatever you locate, you're not going to be able to do much with. So you got to start in a shorter, middle range.
I think you should do it on TJ.
Here, switch.
Bryson, tell me how that experience was for you.
Okay. So, have you worked out arms recently, by chance?
Yeah.
When'd you do
this
it?
whole week.
All week?
Yeah.
Okay. Every day's arm day?
Every day.
Okay. So like for some people, you can just go like this and you can feel like a strip that's just automatically more dense. Like that's a little bit softer. If you just strum across the whole thing, so you got a fat pocket there that feels a little dense. If we come into this medial part, that's a little smaller area that feels a little more tight. You feel that? Okay. So since this is a bigger chunk right here, I'm gonna move this up. Now, I'm gonna get 2 finger pads next to each other, maybe even 3, like cascading. And then I'm gonna move you And I'm just feeling for which little section feels like it could be getting a little tighter. Which one's talking to me the most? And I think that one right there. So I switch. I'm going to move a little more. So now I've fine-tuned to one finger pad. I'm going to move you slowly back and forth. And this is where it does move around, so you got to go slow. Probably right there. Now I can put a little input right into that. Give it a little push. And just hold it.
Yeah, I feel that. You found that real good.
And then I'm just going to hold it until I feel like it moves under my finger or it slides with me. Not me sliding over it, but it slides with me.
Are you just holding that down?
Just, it's a little down and a little up. Can you feel the direction of it still? And now I'm starting to feel it change a little. Can you feel it changing a little?
Yeah.
Okay. And I haven't moved. And as you start to think maybe it's moving more, you can give it a little extra push, like barely enough to feel. Still holding.
And I felt that like
Yep, and I can feel it too. And again, it looks like nothing's happening. I,
Like the pressure releasing,
it's like
or the tissue
it's like something like this goes into something like this, and then gets longer. It's like it flattens out and melts. I'm gonna leave it there.
Yeah, I gotta take my one.
Okay.
Good job, guys. Good job, team.
All right.
Good job, Nathan.
Much better video this time. Thanks.
I had